Welcome, and thank you for joining us today. My name is Chris Perrone. I am Director of Improving Access at the California Healthcare Foundation, and I am delighted to be here with you today. The California Healthcare Foundation, for those of you who don't know us well, is an independent philanthropy dedicated to advancing meaningful, measurable improvements in the way that healthcare delivery systems provide care to the people of California, particularly those with low incomes. We work to ensure that people have access to the care they need when they need it and at a price they can afford. We're based in Oakland and have an office here in Sacramento. Today's discussion is one in a regular series of briefings we convene to provide information relevant to key healthcare issues and trends and to increase dialogue on possible solutions to the big challenges facing our state. Our next briefing is scheduled for Monday, May 6th on expanding scope of practice for nurse practitioners. In addition to those of you we have here in the room, we have over 200 people joining us by webcast and on the phone. And a videotape of today's session will be available on our website, chcf.org, within a few days. I want to thank, before we get too far into this, our Sacramento team, Katie, Danny, Crystal, who am I missing? And then the team, Karen Shore and her team from Golden State Consulting for helping us organize and put this event on. Very much appreciate it. Our topic today is improving quality of care in Medi-Cal managed care, a program that has doubled in size and enrollment in just the last 6 years, and one which has had to adapt over time to meet the needs of an increasingly complex populations and to more enrollees living in rural areas of our state. There are innumerable ways that one could approach this topic, and today our goals are to understand the challenges better and discuss ideas for how the state could address them. We will feature findings from 3 CHCF projects. We will hear first from Dr. Andy Beinman of UCSF about his study examining quality of care trends and consumer experiences in Medi-Cal managed care. Andy's going to be looking at trends over the past decade and also examine differences by plan ownership. Next, we will hear from Beth Waldman of Baylor Health. Beth will provide recommendations for strengthening the state's management and oversight of Medi-Cal managed care based on a review of current practices of the Department of Healthcare Services, of CalPERS, of Covered California, and 5 other leading states. Beth will highlight some best practices and offer some recommendations. The full set of recommendations that Beth and her team from Baylor Health developed are in our report, which I think you have on hand and is available on chcf.org. Last, we will hear again from Beth, who will take a deeper dive into one of the recommendations, using financial incentives to ensure value and align incentives for performance. Specifically, Beth will describe the process and outcomes of a CHCF-sponsored project to develop a recommended set of quality measures to include in a financial incentive program tied to plan performance. This report, too, is now available on chcf.org. Following our 2 speakers, and after a short break to grab lunch, I will facilitate a panel discussion with a distinguished group of thoughtful, pioneering, and collaborative leaders. Jennifer Kent, the Director of the Department of Healthcare Services, Sarah DeGia, CEO of the California Pan-Ethnic Health Network, Brad Gilbert, the CEO of the Inland Empire Health Plan, and Bob Moore, the Chief Medical Officer of Partnership Health Plan of California. Bios for each of our speakers and for our panelists are included in your packets. Last, we will have about 30 minutes at the end of the session for you to pose questions to our speakers and panelists. So one piece of housekeeping before we get started. In your packets, you will find an evaluation form. We would truly appreciate if you would complete and turn this in before you leave. And feel free to get started on it as we go along. So without further ado, I'm going to hand things over to Dr. Andy Beinman.
Good morning, everyone. Terrific to see you all. Nice to have a big group here for this very important topic. And thank you very much to the California Healthcare Foundation and to Chris Perrone for providing me with this opportunity. As Chris said, I'm going to really focus on some of the data that's available about Medi-Cal managed care to set the scene for the discussion that will follow. California, unique in so many ways, was also the first state to implement Medicaid managed care. And as Chris alluded to, the program has grown. It's not only grown in enrollment size, as Chris alluded to, but also the use of managed care as a way of furnishing the services has grown over time. Over the past decade, it's grown from 3.5 million to over 10 million beneficiaries are receiving Medi-Cal services through managed care. And if you put that in a national context, more than 1 in 5 who are in Medicaid managed care reside here in California. Most of the way that people get into Medi-Cal managed care in California is that it is a mandatory program for Medi-Cal beneficiaries, and more than 80% of Medi-Cal beneficiaries are in managed care. It's actually most eligibility groups are required to be in managed care. Some of the groups that are not included in that include those who get, for example, emergency Medi-Cal services, dual eligible, some of whom are in a program right now where it's being evaluated as a possible delivery model. And foster children, for example, are not required to be in Medi-Cal managed care, but most eligibility groups are required to be in managed care. Now, the way that we deliver managed care in California differs by where you live. And this map really sort of highlights that it's not just sort of randomly all over the map, it's somewhat geographically organized. And there's 3 main model types, and I'm sure you're familiar with this terminology, but this kind of gives it to you in a visual way. So the darkest green, sort of that olive color, which you see up north and coming down along the northwest, that represents where the county organized health systems are. And you can see that going down much along the coast. The county organized health system is present now in 22 of the 58 counties. County organized health systems you can think of as a single public plan that delivers managed care services for all Medi-Cal beneficiaries in those counties. Then we have the two-plan model, which is basically there are options of either having a public plan, and the public plan is generally referred to as the local initiative in those counties, versus a for-profit managed care plan. And there are 14 counties that are in using that model, and it's represented by that lighter green color. And you can see that it's more prominent in much of the Central Valley. It's a little harder to see, but San Francisco is an example of it as well along the coast. It's sort of an exception along the coast in a sense. And that's where the two-plan counties are. And then we have 21 counties in various forms of what I would call competing commercial plan models. And those competing commercial plans, the original ones that you probably heard of was geographic managed care, present in Sacramento County and also in San Diego. But it's also been expanded in different formats. In Sacramento and San Diego, there are more than 2 competing commercial plans. But when you get down to in the regional model, which is represented by blue on the map and mostly on the eastern side of the state, it's just 2 competing commercial plans, or Imperial 2 competing commercial plans. There's one exceptional county where there is managed care, but it's on a voluntary basis, and that is in San Benito County, which offers a single commercial plan. If you look at this kind of mosaic across our state, it actually breaks down that as of 2017, there were 22 insurers participating in Medi-Cal managed care. 4 of them are for-profit plans that have about 3 million enrollees. There are 3 nonprofit plans that have about 400,000 enrollees, and there are 15 public plans that serve about 7 million enrollees. These different insurers have to report on their quality, which is what I'm going to be highlighting for you here in a moment. They do that through 31 different county reporting regions. And what do I mean by that? Well, in 22 cases, they're reporting on the quality in a single county. But particularly in more rural areas where the population is smaller, it's clusters of counties. So there are 9 clusters of counties in addition to the 22 single county reports about quality of care. And then because of how the plans are aligned in those different counties or clusters of counties, it turns out there are 53 managed care plan assessments that one can make. 26 of those are for-profit, 4 nonprofit, and 23 are public. And what are the plans being judged by? What is the essence of what we know about their performance? Well, it comes in the form of 2 major types of information. One, which you may know by the name of HEDIS. It's spelled out there what that stands for. A HEDIS is a tool that is a standardized quality assessment tool used in health plans around the country, and specifically is used in Medicaid managed care plans around the country, which provides an opportunity not only to see performance here in California, but to be able to benchmark it against national data. The basis of the reports that are generated for HEDIS come from either administrative data or, for some measures, a combination of administrative data and chart review. It is reported on here in California on an annual basis. The scoring is basically the percentage of people who are eligible for a particular measure and how they score, the percentage of people who either did have the thing or didn't have the thing, and I'll go into details about what those measures are in a little bit a moment here. And here in California, the bar has been set that the minimum performance level that the Department of Health Care Services has set for managed care plans is to exceed the 25th percentile nationally, and that if a measure is below that at a health plan, in many cases this triggers the requirement for a health plan to implement an improvement plan. So that's the 25th percentile toward the bottom is what would trigger that. In addition to the annual HEDIS measures, California also measures patient experience using a separate tool called CAHPS. And again, it's spelled out there what CAHPS is. CAHPS, again, is a standardized way of capturing such experience. We collect this here in California not every year like HEDIS, but every 3 years. And the way that it's reported out publicly is using a star rating system. And you can see how those stars pertain to different levels of performance. 1 star, for example, being at the 25th percentile of performance, 5 stars being at the greater than 90% level of performance. So what we did as part of our study, we wanted to look at a few questions about what performance has been like in Medi-Cal managed care, particularly how has it changed over the last decade, and are there differences in quality of care or improvement over time based on the ownership of the plans. We have for-profit plans, nonprofit plans, and public plans. They vary in their performance and how they're improving over time. We also have, as I showed you, these different models, the COES model, the 2-plan model, these different competing commercial models. Does that result in different quality as measured by HEDIS and CAHPS? And then finally, I'll get into this in a little bit more detail in a moment, but California also has something called an auto-assignment incentive as a way to try to create competition where there are multiple plans in some communities. And the question is that auto-assignment incentive having an impact on quality of care? Where that incentive is, does that result in more rapid improvements in quality over time? What did we use as the data for this study? Well, we took advantage of the publicly reported information the Department of Health Care Services makes available on HEDIS and CAHPS, and we took advantage of the most available past 10 years. There should be very soon a report for 2018 coming out, and we hope to be able to add to our report that information, but this is the most current 10-year information, 2008 to 17. During this time period, I should tell you that some HEDIS measures were phased out, Some measures were phased in. To the degree that those measures existed within a time period of our 10-year period, we analyzed them as part of our work here, even if it was for a shorter period of time. When we tried to determine how quality has changed at a statewide level, we wanted to recognize the importance of the fact that different plans are of different sizes, and so we weighted the quality scores by the size of the plan so that we could understand at a state level how are we doing from a quality perspective here in California. And then when we wanted to compare the different kinds of plans by ownership and different models, we wanted to recognize the differences across the counties with regard to the demographics of who lived in those communities, as well as what the available supply of physicians were there. The way we took advantage of the demographic information is we focused on those below 138% of the federal poverty level because, as you know, that's the cutoff that is used in many eligibility determinations for Medi-Cal beneficiaries. And we specifically looked at information on race, ethnicity, education, and English proficiency as those demographic variables that we were adjusting for. In the analyses I'm going to show you, we adjusted for the number of physician FTEs per population. I'm not going to show you here today, but we also looked at the number of primary care physician FTEs per population as well. And the data were so similar, I didn't bring it to show here, but you can think about that when we come to questions. So first of all, here's the first finding, and that is that quality of care over the past decade in Medi-Cal managed care has been inconsistent. So looking first at the CAHPS measures, which are the patient experience measures where patients report on their experience, and this is only for the period of 2010. There was another measurement in 2013 and a third one in 2016, because remember, CAHPS is done every 3 years. 5 of the measures did not statistically change over those 3 assessment periods. Those 5 measures being the rating of the health plan. You can see that it was 1.1 stars in 2010 and it was 1.1 stars in 2016. And as a reminder, 1 star is below the 25th percentile. Rating of all health care went from 1.2 stars to 1.5 stars. Rating of personal doctor, 1.6 to 2.0. Getting needed care, 1.3 to 1.1. And getting care quickly also stayed relatively flat. There was one of the 6 CAHPS measures that was available to be analyzed, and that was doctor communication, which did significantly improve from 1.3 to 3.0 stars during the observed time period. What about HEDIS? HEDIS measures, 19 of them improved, 11 of them declined, and 5 of them remained statistically unchanged. And to give you a feel for which ones those were, we can see that basically the quality improvement areas, the ones that tended to improve, were in the area of children's counseling. There were 3 measures associated with that, and you can see the level of improvement there. In the area of diabetes, there were 3 measures specifically that improved related to testing, diabetes control measured through hemoglobin A1C, and the percentage of people in poor control declined from 43 to 38%. That's a measure that obviously works in the opposite direction. You're trying to have fewer of those rather than more of those. Blood pressure control improved a little bit from 58% of the people to 62%, and breast cancer screening went from 50% to 58%. Now, I'm highlighting those as improvements. We could also talk about whether the absolute performance in those still meets our expectations, because there are still significant numbers of people getting very basic things that are quite significant to improving morbidity and mortality that are not being achieved. In terms of the areas that declined, it was particularly prominent in children's measures and in important care for women. So you can see that access to primary care for children across multiple age groups declined over the 10-year period. That was also reflected in a decline in the percentage of children who got an annual well child visit between the ages of 3 and 6. Childhood immunization rates dipped a little bit. Now, you're going to say to yourself, that's a very small decline, but I would also remind you around all of these that when things are statistically significant, they can still be quite meaningful at a clinical level because of the numbers of people who are represented through these percentages. So childhood immunization declining. This is, of course, a very hot topic here in California, particularly as we are talking about things like the measles outbreak that is going on here in our state. Timely prenatal care also declined during this time period, as did cervical cancer screening. So all of these areas related to women and children went in the direction in the wrong direction during the last 10 years. Now, consistent with this is if you look at what proportion of the measures actually fell below the 25th percentile nationally. And this bar graph shows you the absolute number of measures. So this is not, so if a plan is being measured, for example, on 35 HEDIS measures, they would be identified if one of their measures fell below the 25th percentile. So back in 2008, there were only 66 measurements that fell below that 25th percentile. You can see that this actually started to climb over time and really peaked in 2015, where there were 302 of the measures that were below the 25th percentile. Now, you should also recognize that our use of Medi-Cal managed care and the number of plans grew over that time. So a way to get a sense of is this a percentage change or not, is to look along the bottom x-axis, where I provided for you the percentage of all the measures that were made in each of those years, and what percentage of those measures fell below the 25th percentile. And in fact, you can see that in 2015, 2016, that we were up over 20% of the measures that were being made were below that 25th percentile. By 2017, that seems to have been improved somewhat, and we're looking forward to seeing what happens with the data in 2018. Now, something that I think is also really important to understand is that these quality deficits that we're identifying really do vary quite a bit based on the managed care plans and which ones are involved. So there are large differences in quality across the different managed care plans each year. Interestingly, it doesn't sort of just randomly move around. Plans that perform at a high level one year tend to perform at a high level the next year, and the opposite is also true. When we look at the year-to-year correlation in performance by plans, it's up over 0.8%. So it's a very consistent performance at a plan level. And that performance definitely varies by the ownership of the plan, whether or not it's for-profit, nonprofit, or public. And just to give you a sense of the range of how different plans are performing with regard to some measures, I've put up some measures from 2017. So access to primary care for children ages 1 to 2 varied between 81% and 98%, so about a 20% difference there. The cervical cancer screening rate in an even wider range. In some plans, only 38% of women getting cervical cancer screening, whereas in other plans, exceeding 86%. And of course, the goal here is to have it be 100%. That is what would be indicative of the highest quality care. Childhood immunization, again, an incredibly important health issue for children as well as a public health issue. Highly variable from 55 to 83%. Diabetes control, also quite a wide range. And blood pressure control, one of the most basic things to do to improve and lower the risk of heart disease, heart attacks, ranges from 45 to 89%. So what plan you go to has an enormous impact on the quality of care that you receive as a Medi-Cal beneficiary. To further highlight this, what we did was we started to rank each of the plans on all the measures that we were looking at, the 41 measures that included the 35 HEDIS measures and the 6 CAPS measures. And we basically looked on an annual basis and ranked the plans on how they did on each measure and then summed up those ranks together to be able to, on the right-hand side, is basically the way we ended up organizing the plans in terms of from best to worst. Now, it's not important that you be able to read the names of the plans here. You'll be able to do that when the report comes out. But we color-coded for you there the ownership type of the plans. So in that yellow color are the nonprofit plans, in the teal color are the public plans, and the plans that are basically shown in white are the for-profit plans. And you can see that there's a difference in the distribution where the yellow plans are sort of up toward the top, the teal plans are sort of up, closer to the yellow plans, and then the white plans are definitely dominating the lower part of the graphic. And that corresponds to the fact that the for-profit plans, on average, are not performing as well as the nonprofit and the public plans on average across the state. And you can see this more clearly in this line graph. So the line graph, the top graph, represents the for-profit plans. The orange line is the nonprofit plans, and the blue is the public plans. And on the left-hand side of the graphic, and that's moving out over time, and the higher you are on this graphic, the worse the quality of care as measured by HEDIS and CAHPS. And you can see that the for-profit plans really stand out each year as having a worse quality score. The nonprofit plans, on the other hand, you can see sort of started off in the middle if you go back to 2008 and have actually come out to be the highest performing in more recent years. And the public plans, which were trending as the best performing in the earlier years, have actually trended up a little bit more recently. Now, on the right-hand side of this graphic is where I've then adjusted these results based on the county demographics and the physician supply per population. And you can see that that's the dashed lines that correspond to a subset of the years. We did not have data on the physician supply for all the years of the study. We only had that for 2011, 12, 13, 14, and 15. So that's just 5 years of the 10 years. But what you can see during that time period is, again, the nonprofits are performing the best, followed by the public plans, and then the for-profit plans really stand out as distinctively, and they do test statistically significantly worse in performance, even after adjusting for county demographics and the physician supply. Another way that this is reflected in the data is coming back to the information on what proportion of the measures are below that 25th national percentile. And this table shows you that in terms of the total number of measures that were made by for-profit plans, they constituted during the time period 47.5% of the measurement was among for-profit plans. Yet 66.8% of all the measures that fell out below the 25th percentile were attributable to the for-profit plans. On the other hand, nonprofit plans, their measurement, because there are a much smaller number of plans that are nonprofit, was 9.8% of the measurements, and they reflected only 5.3% of the measures that fell below the 25th percentile. The public plans are 42.6% of all the measurements taken, and yet they have only 27.9% of the measures that fall below the 25th percentile. So on a proportional basis, the for-profit plans really stand out as having more of a challenge of getting above the 25th national percentile. Now, you may say, okay, you did adjustments for the county demographics and the physician supply, but there still may be unmeasured differences in the different counties in terms of where these plans are that might explain what's going on. So another way that we thought to try to take a look at this was in the two-plan model counties, where there's a public plan directly in competition with a public plan in direct competition with a for-profit plan. And so we limited in this analysis looking at just those counties, and we then ranked the plan's performance across all of the measures. And what this table summarizes is in how many of the cases did the public plan come out statistically better than the for-profit plan and vice versa. And in the case where you see a half point, that means that they were statistically tied in terms of their performance. So if you look, for example, in 2008, there were 8 such counties in which there was a competition that we could look at, that there was a public plan in competition with a for-profit plan, and in 7 of the 8 of those cases, the public plan performed statistically better. And going down the line, you can see that this is quite consistent throughout all the years. So let's take a look at the last question I wanted to get at, which is related to, does the model matter? And so, it's important to think about competition among managed care plans has the potential to drive quality improvement. We think of choice and consumer activism as an important part of driving quality in many sectors of our economy. And there are choice of 2 or more managed care plans in 34 of the 58 counties. In general, the counties that provide managed care services through a single plan tend to score better on average on the quality measures than those relying on multiple plans, even after adjusting for the county demographics and the physician supply. Having said that, and I think it was reflected in a line graph that I showed you earlier, some of those differences are becoming less prominent over time. As the single public plan model has expanded over time, this difference has become less visible between the models over time. Yet during the 10-year time period, in general, a single plan has performed better than multiple competing plans. Now, one way that multiple competing plans are incentivized to try to compete with one another is through an auto-assignment incentive. And this is this general idea that beneficiaries who do not choose a managed care plan are sort of a prize to be had. Those that don't choose a plan are probably less likely to engage with services, and yet the same amount of capitation is provided for them. And so in a way, they're a potential beneficiary for whom a health plan could see some profit margin because the cost of caring for them may be less than the cost of what's provided to care for them. And so a auto-assignment incentive was created whereby those individuals who do not actively choose a plan in which there are choices to be made would be assigned to plans in proportion to the performance, in part related to some HEDIS measures. And there were 5 measures in particular that were the basis of determining how that auto-assignment should happen: cervical cancer screening, diabetes control, timely prenatal care, well child visits for those ages 3 to 6, and childhood immunization. And so what we did was we looked at, okay, so in those plans that are having a competition around those for the auto-assigned beneficiaries, you would think that that would stimulate quality improvement in those measures. So we looked specifically at those 5 measures, and we compared the different models. The black line in this graphic represents the COES model, in which there's just a single public plan, so they're not subject to the auto-assignment incentive, whereas the blue line represents the 2-plan model, and the red line represents the GMC, or competing commercial plan, in this case. And what I can tell you is that the single public plan outperformed the competing competing plans in those counties that had the auto-assignment incentive. So you can see that in all the counties, in general, in many of these measures, the performance actually was drifting down over time. It did not always consistently improve, but the drifting down was actually worse in counties that were having the auto-assignment incentive as compared to the COES county, which wasn't even subject to this auto-assignment. And this is, if you look at like timely prenatal care in the lower left, this is particularly apparent where the COES is staying flat or actually going up a little bit, but the competing plans are actually declining. And this was true across 4 of the 5 measures. So let me summarize for you. Basically what I've shown you is that here's what we know. Quality in Medi-Cal managed care has been inconsistent over time. Quality scores in Medi-Cal managed care are often below the 25th percentile nationally. There's been particularly a decline in children's access to care and women's health measures. Quality varies across managed care plans and by the ownership of those managed care plans. And managed care plan choice is not enough to drive improvement. Here's what we don't know from the data that I showed you. What are the characteristics of the managed care plan enrollees? That was not publicly available for me to be able to directly try to adjust the results. I adjusted the results based on county demographics, but did not have plan-specific information. Had I had plan-specific information on demographics and the eligibility of the people in those plans and information on that in HEDIS and CAHPS, I could have been able to tease apart important differences potentially in how plans perform with different eligibility groups, for example, TANF versus SPDs, or how they do perhaps with regard to highlighting disparities in care, not just overall quality, but differences by race and ethnicity. That's not available in the data. Also, some of the plans do delegate their services to other health plans. None of that information is visible in the data. In terms of what to make of this managed care plan variation, it's not due to county demographics, as I showed you. It's not due to the total or the primary care physician supply differences in counties. Some of it could reflect unique differences about where these managed care plans are. As I showed you, there are some county regions where there aren't any public or nonprofit plans. Maybe there's unique things that are going on there in those rural areas. But I would say the head-to-head competition between public and for-profit plan certainly suggests that there are differences in performance between public and for-profit plans that should be taken seriously. I think what's important to unpack about all of this is to think about what's underneath the plan. The care is not directly delivered by plan. It's delivered by clinicians working as part of the network in those plans. And what we don't have information on publicly is what are the differences in the provider network capacity across those different plans? What are the differences in the penetration of the plan in those providers' practice? Because had there been a tighter association, that might be associated with higher quality of care as well. Does it have to do with differences in that provider network in terms of how integrated it is or how dispersed and isolated it is? There are clearly probably differences both between urban and rural, but also even within different counties in terms of how that's done. Having better information on the networks of the physicians who are involved could help us better to understand these quality differences. And also, are there differences in the investments that managed care plans are making in primary care, information technology, and other key strategies to really try to support care management across these different plans? And finally, let me just say that in terms of when it comes to managed care plan choice in Medi-Cal, it's clearly less administratively efficient to have multiple plans than it is to have a single plan within a county. Yet, on average, we are producing lower quality in these counties that have multiple plans than we are in counties that have a single public plan. Having said that, that performance difference is becoming less apparent as these models have expanded over time, and we need to understand whether it's the model or something else that is driving some of that difference. Is it differences in those networks? Is it a learning curve associated with getting started with a plan? This is something I think we have to judge over time. And finally, the auto-assignment incentive is not resulting in the improvements in quality. It was a very good idea as a way to try to create an incentive, but it does not seem to be substantial or significant enough on its own to really be driving improvement. So thank you very much. I'm going to end here and just want to acknowledge some of the people who assisted me in putting together this work, and look forward during the panel discussion to have a chance to engage with you about these results. Thank you very much.
Good morning, everyone. I am up next. My name is Beth Waldman, and I am from Baylett Health. Happy to be here this morning where it's much warmer, I can tell you, than it has been in Boston. So I am going to take us back a step from honing in specifically on quality measures, and I'm going to talk about oversight of the Medi-Cal Managed Care Program as a whole, and you'll see as we go along that some of it will include a focus in on the quality measures that Dr. Byman just talked about. So let's jump in. You have already heard from Dr. Byman and know that your Medi-Cal program is the largest in the country. I know, as a former Medicaid director myself, to actually run a Medicaid program. So to run one that's the size of California and keep your trains running and really just get beneficiaries enrolled, pay the bills, all of that is a huge feat. And so, so as we think about what we're recommending here and what we're going to talk about, it's not to detract from any of the good work that DHCS has done, but really to build on that and leverage their good work. And that's because there have been some ongoing concerns about access for enrollees. And as you heard from Dr. Byman, there's certainly some room for improvement in the quality of care. There's also some growing concern about transparency for both state officials and enrollees on access, quality, and the financial health of the medical groups to which Medi-Cal managed care plans will be delegating their financial risk. So last year, with the new administration and the start of the Medi-Cal managed care procurement on the horizon, CHCF asked us to look into how the Medi-Cal managed care program was administered by DHCS, and to recommend some additional steps that the department could take. So as part of our approach, we identified strategies and tools used by active healthcare purchasers. We reviewed managed care plan contracts, both in California, including those for Medi-Cal, Covered California, and CalPERS. And then we looked at 5 states: Florida, Massachusetts, Tennessee, Texas, and Washington. And we picked these states because we knew from our own experience nationally that these were among the most active purchasers, and they also happen to, for the most part, have relatively new procurements. And then we interviewed some experts. We talked to public purchasers, Medi-Cal managed care plan executives, consumer advocates, and others in California. And then we also interviewed the Medicaid managed care plan in the other states that we looked at their contracts. So this is one of our favorite slides that we use at Baylett Health Purchasing. And it's about purchasing as an ongoing effort of value. So it's important to understand, as you're thinking about overseeing a contract, that you really want to have an ongoing process that begins with defining a procurement approach and vision, and then continually monitors, measures, and modifies the approach to improve quality and outcomes, using both financial and non-financial incentives and penalties. And really at its core, the value-based purchasing model encourages purchasers to move beyond a compliance-based approach to one that's really focused on a collaborative partnership with plans to help improve performance and advance the purchaser's vision. Using this as a platform is really how we focused on everything that, looking at what Medi-Cal could do, what other states could do, and what our recommendations were. So we came up with 10 recommendations for the state as the basis of our work. And again, I just want to acknowledge that DHCS does do a lot of good things, and this is really building on the work they do, which has generally been compliance-based, and move DHCS to be a more active purchaser of Medi-Cal managed care. So I'm going to talk about 5 of the 10 recommendations today, but I do just want to spend a minute or two focused on those that I'm not going to talk about. So under the immediate recommendations, I'm going to talk about the first 4 bullets. But for the 5th bullet, establishing regular plan-specific leadership meetings, I just want to suggest that it would be helpful for the state to really focus in on having an annual face-to-face meeting with each of its plans. I understand that there's a lot of plans in California, and that it's not as easy to do here as it is in states with smaller number of plans. But you do have states that have bigger plans, that have bigger proportions of your members. And there is a way for the state to focus in on having annual meetings, really creating strong partnerships with those plans that have your largest membership or those plans that are struggling the most to help them move along and create a partnership. Again, I understand that it's really hard to do this for all plans, but to move the value-based purchasing cycle along and to be an active purchaser, those annual meetings will be important. In terms of longer-term recommendations, I'm going to spend some time talking about ways to improve operational simplification and coordination of oversight, but want to just spend a little bit of time before we move on for the last four. So to pursue greater alignment across DHCS initiatives and with other large purchasers. So DHCS does a lot of things. The Prime waiver is a good example where there's a lot of activity moving forward that's not completely intertwined or aligned in its managed care contract. And if the state were to do that, it would really sort of help move the needle forward in the healthcare system a little faster perhaps. And the same is true for aligning their work with that of CalPERS and Covered California. It's not always going to work. There's certainly areas where it's not feasible or appropriate, but having a continued appreciation for how it could move it forward in the right circumstances is important. Building upon efforts to improve access to care and measuring network adequacy, we saw from the CAHPS results that they're really not that great. And so the more you can do to continue to improve access and measure your network adequacy will be important. DHCS has done a lot of work in the past couple of years to improve this. There were new requirements in the Medi-Cal managed care rule around this, and the state has certainly done a lot. But we do know that there is a lot more to do, and the potential really here to focus in on some performance incentives for the plans to help them sort of focus in on increasing both access and really reducing the amount of alternative plans needed for the network adequacy. And then the last two are really might seem simple, but I think important. One is implementing a calendar of activities. The state already does have a calendar of activities, but it doesn't really focus on quality improvement, and really putting quality improvement steps into the calendar of activities could be a way to continue to keep quality at the forefront of everybody's minds throughout the year. And then finally, investing in staff. The Medi-Cal program does have the DHCS Academy, where it trains staff who they believe have potential for leadership roles. Really think this is a best practice across the country. What we would recommend is, in addition to doing this, that the state also invest specifically in staff that are focusing on managing the managed care contracts. A lot of staff come in and don't have any experience, and they are working in partnership with plan executives who have a ton of experience. And so you're not really on an even playing field working as partners, and we really think that could be helpful. Okay, so now we're going to dig into the specific recommendations that I'm going to talk about today. The first is to articulate a strategic vision for managed care and to apply that vision to the managed care contracts. So this is a great time to do this because the state is about to go through a Medi-Cal managed care re-procurement. It is on the horizon, and establishing a 3 to 5 year vision that coincides with that re-procurement will really help set the tone for what you want to get out of your plans for that 5 years and where you want them to focus their improvement. It will be important to translate the vision into revised contract language that really focuses on specific and measurable goals for the managed care plans. And really, again, shift the focus from compliance to excellence and continuous improvement. That really is sort of an ongoing theme, I think, of what you'll be hearing from me today. And you also want to establish a process for tracking the progress against these goals and really sort of ensuring that you're continually moving yourself, reviewing the vision, and that you're sharing your vision with stakeholders. So what do you do today? You do have a vision. The state does have a vision. It's just that at this point it's probably a little stale and not something that is clear in the minds of either the plans or the stakeholders. And so the plans and the stakeholders then don't really know what this state is striving to do. We know that Governor Newsom has come in and he has really started off with starting to articulate a new vision for oversight of the Medi-Cal managed care plans and a greater focus on and children's health. And so this is definitely a step in the right direction and a step towards having a focus again on the continuous quality improvement. As an example of a best practice state, Massachusetts recently went through a re-procurement, and as part of that included a very clear vision statement and specific measurable goals and objectives that are distinctly linked to the managed care scope of work. And in our report, you can see the full set of goals that Massachusetts put forward. As they were doing this and as they were putting their managed care procurement together, they held a number of stakeholder meetings. In Massachusetts, it happened to be a lot of stakeholder meetings because they were really changing the basis of how they were procuring managed care. But even if you're not doing a full-on change to how you're procuring, really having ongoing conversations and getting input and buy-in from your stakeholders as to what your vision is and how you're going to implement it is really important in order to ensure that you have the buy-in once the contracts are in place. The second recommendation that we have is around strengthening oversights of managed care plans that delegate risk to another entity. And you heard in Dr. Byman's presentation that he wasn't able to tell what happens when there's a delegated entity. That's true in from a quality perspective. That's true from a network adequacy perspective as well. It's not necessarily clear what is happening. And so we're recommending that as part of a new procurement, that Medi-Cal include new requirements on the plans around how the plans oversee those to whom they delegate responsibility. And that's true whether or not it is a provider group that they're delegating risk to, or it's a subcontractor, like if a plan is gonna subcontract out, say, behavioral health isn't a great example in California because it's done separately, but that happens in a lot of states. So it's important to really have some clear requirements for what the plan has to do in overseeing and making sure that the plan's requirements are really passed on to the delegated entities within the contract. And so having some strengthened contract language around that, and particularly around financial solvency, around how the plan's network and the delegated entities network is going to work together, and where there's particular capacity within that network that will be used for the plan, and then having referral policies and beneficiaries' ability really to access that care that's part of the network. And then we also recommend that there is the requirement that managed care plans report to the state on their use of risk-based alternative payment models with provider entities. These reports really can give the state a better understanding of to whom these contracts are happening and what is happening with them, if they're being successful, if plans are at risk. And so what you're doing today does comply with both the state and federal requirements for what you need to do for delegated entities. So I want to be clear about that. What we're suggesting is another step forward to give both the state and beneficiaries more comfort in in these delegated entities. Today, DHCS provides less direct oversight of delegated entities and subcontractors, but when there's a problem and they know about it, they do jump in and help. So it's not that the state is completely hands-off. And we do understand that the state is currently reviewing its process for monitoring subdelegates and thinking about ways to add components to their audits in the future. A best practice state to look at is Florida. In their most recent procurement, they have all sorts of requirements around what their plans have to do around delegated entities, including the submission of financial statements for the managed care plans to review. Because if you're going to give risk to somebody, you want to understand that they actually can take on the risk. They also require that their subcontractors or their delegated entities maintain an insolvency account equal to 2% of the subcontracting value. So that gives some assurance that if something goes wrong, there's some dollars to help cover the claims. Where claims processing and payment is delegated, there's also another account on top of that that's required. And then finally, if there is a failure from either the plan or the delegated subentity, subcontractor to comply with any delegation requirements, the plan could be subject to penalties. And so that's really important because it puts the plan on notice that they're taking on the responsibility for monitoring these delegated entities. Okay, so our third recommendation brings us back to our focus on quality measurement and reporting. I think our overall recommendation is really focused on making quality improvement an integral part of the contract management and a focused discussion between DHCS and plan leaders. And this brings me back to the ongoing leadership meetings with the plans. It's really important to set minimum managed care plan performance levels that are measure specific. So as Andy noted today, the measure is a minimum 25th percentile. But for some measures, the state is way above that. And for some plans we know are not. We saw that 10% are not at that point. So really setting some performance levels that are plan, both measure specific and potentially plan specific really help focus the improvement. Because today, if 25th percentile is all you got to do and you're above that, then you don't have any incentive as a plan to do anything to improve your quality. And I think you see that in the quality scores that you saw from Dr. Byman's study. It's really important to give the plans a reason to focus on achieving excellence and continuous improvement over time. And to create improvement targets for each measure based on where the plans are. You want everybody to try to improve. So you're going to have some plans that are really performing poorly on particular measures. You want them to improve from where they are. Some plans that are in the middle, you still want them to improve. And even on the higher end, I'm sure that there are very few, if any, that are performing at the very, very top of the national percentile. And so there's always room for improvement. We know we're not going to get to 100% on everything, but you really want to push your plans to improve from where they are. You also want to have regular review and share plan level and program-wide performance data to prioritize oversight activities. There is certainly some of that happens in California today. We would really focus on having a much greater emphasis on that and on continuing to pursue efforts to have greater alignment on measure reporting and improvement expectations across Medi-Cal, along with Covered California, CalPERS, and the Integrated Healthcare Association. So today, today, as you know, there is external quality review and audits. We heard about the auto assignment from Dr. Byman. There is a fair amount of reporting actually in California, public reporting on quality measurement in plans, and I think that is more than a lot of states do, but I still think it could be improved, and it's, as I said, sometimes hard to find. There are efforts to recognize plan quality performance at all plan meetings, but that's not the same as having a really public rewarding of quality. For those that are below the 25th percentile, as Dr. Byman mentioned, there is corrective action plans or improvement plans. Those plans really are, and the similar plans are used when there's an audit and somebody doesn't meet compliance. And those plans really are quite good and comprehensive, but they really are only getting you to compliance. Again, they're not sort of moving to continuous quality improvement. There has been an external measure set that has been used by the state for a number of years. Governor Newsom has proposed expanding the measure set to include all adult and children core set measures, and again has recommended moving to an established 50th percentile as a minimum performance across measures. When we look at other states, we see all of the states that we looked at really having some focus on quality performance. Again, not all states do that, but we purposely picked states that we thought were ahead of the game. There are very plan-specific public reports in both Tennessee and Texas. In all of the states we reviewed, the plans are expected to improve their clinical quality performance year over year. Again, I just want to contrast that with a minimum compliance of 25th percentile. And then also meet performance measure-specific expectations that are tied to benchmarks. And the plans in these states are required or subject to both carrots and sticks in terms of financial and non-financial incentives based on their performance. So that leads me to our fourth recommendation, which is around applying both financial and non-financial incentives to improve performance. Really, it is essential if you want your plans to do something, you have to require them to do more than comply. You really have to give them a reason. What's the business case for them investing in quality? And it will be important, we think, to up the ante a little bit in terms of the public reporting of where they are in terms of quality measures, and in terms of regularly publishing data about their quality measures as compared to other California plans and the national benchmark. We also think it's important to create both positive and negative penalties around performance. We do know from research that there really is a correlation between providing incentives to plans and quality improvement over time. And there's a particular recent evaluation in the SIM model in Oregon, which shows that really worked in their state. And then finally, you really want to create positive financial incentives for plans that are both high-performing and to demonstrate significant improvement over time. You don't want to leave any of your plans out of your quality improvement strategy, regardless of where they sit today. So I think we talked about most of these current approaches already, and the fact that all of the states that we looked at really focus on this. We'll talk a little bit more about this in the second presentation of a different project that Baylor worked on, focused on the quality measure set. So for the last recommendation that I'm going to talk about today, it's around improving operational simplification and coordination of plan oversight. We know that there's a lot of burden on health plans and providers in California in terms of being a Medicaid provider. And what we heard from one stakeholder we talked to was that California Medicaid pays the less but requires the most. And so thinking about ways in which you can reduce burden on your plans and your providers gives them the ability to focus on things that will really improve quality. So there are lots of requirements on the state to do audits and to have oversight, and those are good things. But it occurs both between DHCS and the Department of Managed Care. And while there are efforts to coordinate that, there can be some improvement. We'd also recommend some potential to reduce the amount of audits where you have plans that are performing well, so that they get a reward for performing well. Maybe instead of auditing them every year, you go to every 2 years or every 3 years on particular aspects or something. I know that's something that's not comfortable for everyone, but as we're moving from compliance to really continuous quality improvement, we want to think about ways where we can reward that compliance and sort of move on from it. So your current approach, as you know, is very audit-focused, which brings to the compliance. Tennessee is a good example of a state that provides both audits and a balance of really continuous quality improvement. So I'll leave you there, and I think I'm going to turn it over to Chris.
Thank you, Beth, and thanks, Andy. Before that, we thought before Beth gets started with her next presentation, we would do a little audience engagement exercise to sort of highlight some of the findings that Andy presented. And so, and plus, I think we all need a stretch. If all of those of you who can stand, if you wouldn't mind standing up, please. Great. You can even stretch if you'd like to. So we're going to do a little exercise that focuses on immunizations for children. Children's care is of particular interest to Governor Newsom. It's the topic of a hearing tomorrow here in Sacramento. And so there are many different measures we could use to eliminate this story, but we thought we would use the children's immunization combination 3 by their second birthday to highlight some of the geographic disparities. So I'm going to ask everybody who's in this first row of tables to have a seat. Thank you. Okay, so all of you standing, congratulations. You represent the children in San Mateo County who got the appropriate immunizations by age 2. I'm sorry to say those of you sitting down did not. And there are many reasons why not all children will receive their immunizations by age 2 in Medi-Cal. And so it's not as though we're looking for necessarily a perfect 100, given the churn in Medi-Cal, given people coming in from out of the state, given that we know we have this more education to do. But this is San Mateo represents the best county in the state with regard to immunizations for children. So now we're going to look at one of the lowest performing county. We're going to look at San Joaquin County. So I want, where is Ann? Okay, so this second row, and everybody who's behind Ann in the third row, if you would also sit down. So those standing represent the children in San Joaquin County who received their appropriate immunizations by age 2. And I'm sorry, all of you who are sitting down, if you lived in San Joaquin, you would represent the children who did not get your immunizations. So a third fewer children in San Joaquin getting appropriate immunizations by age 2 than those in San Mateo County. So we think of Medi-Cal as a statewide program. We should be certainly upholding it to statewide standards. We'd like to see a uniform program applied uniformly through the state. And really, I think this accentuates really the need to lift up and to strive toward continuous quality improvement so that the children in San Joaquin County can get the same quality of care that children in San Mateo enjoy. So thanks for participating. I hope you got a little stretch out of it, and I'll hand things back over to Beth.
All right, so now I'm going to present on the second project that Baylor Health has been working on for the California Healthcare Foundation, and it's around selecting performance measures for a financial incentive program for Medi-Cal managed care plans. The first slide will just give you a roadmap of what we're going to talk about in this session, why we did the work, how other states hold plans financially accountable for performance, what the advisory group process was, how measures were selected, what is in the measure set, what to do with the measure set and the performance once you know what it is, and then some next steps. So for some background, many of you might have seen a report that California Healthcare Foundation published last year at this time called Intended Consequences, Modernizing Medi-Cal Rate Setting to Improve Healthcare and Managed Care Costs, which recommended a financial incentive model to put in place with plans. And if adopted, it would establish positive performance incentives for both improving quality and reducing the quality of care. That report did not focus on what the measures would be, and so the California Healthcare Foundation asked Balit to come in and help develop a proposed measure set. But before that, Balit Health, on behalf of the foundation, put together a report that looks at what other states do to hold their health plans financially accountable for their performance. So in terms of what the other states do, most states don't have any new funding to put forward for holding plans financially accountable. So with no new state funding, there's three basic things you can do. You can put in place a bonus payment funded by a withhold. This is by far what most states do. It's gotten a little bit tricky with some new requirements around actuarially sound rates and how it all fits together. There has to be some reasonable idea that the plans can actually earn the withhold back for the rate to be considered actuarially sound. So if your rates are at the very bottom of the actuarially sound range, it makes it a little bit harder to do this withhold. Shared savings, which allows the plans to have some profit sharing, and then a penalty for poor performance. And then there's methods that can be used either with new state funds or ones that may or may not require state funds. And that's a state-funded bonus payment. That is usually new funds. It's on top of what's in your actuarially sound rates and would give plans a bonus for good quality performance. And then finally, the capitation rate adjustment, which would allow for an increased capitation rate based on a plan's performance. Again, how this works depends on where you fall within the actuarially sound rates. You still have to be actuarially sound from a federal perspective. There is a whole report on this, so I'm not going to get into the details today, but please take a look at the report and see what's happening in the other states. What I am going to focus on today is the advisory group process. So the California Healthcare Foundation convened an advisory group that Balit Health facilitated. It included a series of 4 meetings that happened between October and February, and I have to tell you, it really was a condensed process. When we do these things in other states, it could be 2 or 3 times that time, but really within that short amount of time, the advisory group took on a very thoughtful process to advise on key elements of a performance measure set and a performance evaluation methodology. The way the process worked was really to try to get each member to talk about their own ideas and provide feedback and preferences. The advisory group was not expected to come to consensus, although I think they generally did within their recommendations. But again, the recommendations are not to be inferred as every advisory group member agreeing or their organizations agreeing to everything. Here is a list of the advisory group members that participated, some of whom are in this room. Thank you. And there's a good mix of clinicians, of health plans, of data experts, and consumer advocates that really allowed for some very thoughtful, deliberative conversation about what the right approach would be. So there's generally 7 steps to a measure selection process: defining the selection criteria, identifying domains and populations, identifying measure sources and the data for those sources, estimating the desired set size, selecting measures, and then refining the measure set. This morning I'm going to talk to you about those in bold, the 4 in bold. So here we go. Oh, too fast. Okay, in terms of measure selection criteria, you can see the list that the group agreed on the, I guess, the left. You want to be the measures to be meaningful to both patients and providers. You want it to be something that plans and providers can influence. Again, a reminder that this is a subset of measures that are being used. So it's not all of the measures, but it is the ones that you want to incentivize plans on. So again, you want it to be something that the plans and the providers can really do to make a change. If there's nothing they can do to make a change, then it's just going to be luck whether or not they get the incentive. You want there to be opportunity for improvement, again, because you are looking to incentivize improvement. You want them to be nationally vetted or vetted by a California organization. You want it to have a systematic impact on the health of your beneficiaries. You want it to be outcomes-based preferably. This is really a wish as opposed to something that you can have in a lot of measures today, because we know that most measures are still process-based as opposed to outcomes-based, and it can be really hard, particularly within the next criteria of being feasible to collect within existing infrastructure, to have a lot of outcome measures. And so you'll see some mix in typical measure sets today. Obviously, because we're incentivizing Medi-Cal managed care plans with this measure set, they have to be pertinent to the Medi-Cal population. We really wanted to ensure, the advisory group wanted to ensure that they were aligned with other measures currently in use in California. The advisory group also talked about what domains to focus on, and you can see the domains they agreed on here: patient experience, preventive care and early detection, access, social determinants of health, care coordination, chronic illness. Maternity care and medication management were added later when there was a particular realization that because Medi-Cal is such a big provider of service for pregnant women in the state, it was important to include that. And also the medication management, there was really a desire to include a measure that was focused on asthma, and so including that as well. The group discussed having a particular domain around disparities or equity, but decided that it was important to really measure across these domains with the disparities and an eye towards equity, and not have it as its own thing. That really, for all measures, you should be looking at this. The group also looked at the measure set size. If you think about a measure set, typically the smaller the size, the more a plan can focus on improvement in those areas. The bigger the set gets, the more you dilute what they can focus on. But it is a tricky balance on what to pick, because the plans will focus on where there's a business case, right? So it's hard to balance where you get. The advisory group initially was aiming at getting to 5 to 10 measures. You'll see that they actually ended up selecting 12 measures, so pretty close to the smaller side, but a little bigger to allow for enough breadth of the measures, but really still allowing for some focus of the work. So to get to the measures that were selected, Baylor Health looked at more than 200 measures across 9 measure sets, and winnowed down that list based on measures that appeared in 2 or more sets, and those where there was a high opportunity for improvement. So where the Medi-Cal plans were performing at a level where there was room to grow. The advisory group was also invited to put in some of their own measures if they didn't see something they were interested on the list to talk about it. Altogether, the group talked through 43 measures, and as I said, ended up selecting 12. Again, the strongest measures and where there was most interest was where there was great variability in plan performance or significant room for improvement, where the improvement would have a significant impact on the patient health and improve the health of a large part of the Medi-Cal population, and where there was data already being provided or reported to DHCS as part of the external accountability set. So these are the 12 measures that the advisory group came up with. You can see that there are 5 preventive care measures, a care coordination measure, 2 chronic illness measures, 2 maternity care measures, although I'll note that the prenatal and the postnatal really are separate rates, and then a medication management measure as well as a patient experience. If you compare this list to the list that you saw from Dr. Byman, there is some overlap between where there was poor performance or declining performance and what's on this list, and that is good news. There wasn't overlap in the, we didn't know the results of the study. The advisory group didn't know the results of the study when going through this process. So you can see that people are concerned about things that do make sense. I do want to note that there was not a social determinant of health measure on that list, even though it was a domain. The advisory group did not find a suitable social determinant of health measure to use. That doesn't mean that they didn't think it was important, just that the time is not yet ripe to have such a measure as an incentive measure. There also was a desire to have a depression measure, but wasn't one that the group found to be valid and operationally feasible. And also, they were interested in having a statin measure, but the clinical guidelines are sort of moving around, so they wanted to stabilize a bit before they got there. They, again, focusing efforts on continuing to stratify measurement by subpopulation, so you can see where there's disparity. The CAPS measure, in order for that to happen, would require really for CAPS to be collected every year. As Dr. Byman noted, it's collected every 3 years now, so that would be a change. And finally, the advisory group talked about using the DHCS Timely Access Survey and the Department of Managed Care's access report as potential future data sources when they have more mature methodologies and available benchmarks. In terms of using the recommended measures, so once you have your measure set and you know the plan's performance, how do you reward them? What the advisory group recommends is using both a gate, that is a minimum performance level in order to be eligible for a reward, as well as a tier, that is a higher percentage or incentive level based on your own performance. The group recommended that the gate be no lower than the 50th percentile of NCQA, and that the high achievement targets really vary by the measure and what current performance is. The group also recommends that DHCS set targets at achievable levels on an annual basis. Again, this is to push plans to improvement. You want it to be something that's feasible, again, so that there's a business case. They can see that they have potential to earn these incentives in order to move forward. For the purposes of this measure set, they recommend that all measures be given equal weight in terms of allocating incentives. There are some methods you could do which would prioritize one measure over another, but here they're recommending that it be equal weight. So some key considerations and lessons. This measure set was put in place understanding the report recommending the shared savings model, but really not counting on that as what the model would be. The measure set could be used in terms of any incentive program that was put in place, and really shows that having a thoughtful stakeholder discussion can really get to some buy-in and compromise on things based on having ongoing conversation and collaboration. And so something we really would recommend for going forward in many settings, not just around quality measurement. And finally, it's important to understand that once a financial incentive model is in place, it will be important to relook at these measures and to make sure that they still are appropriate for a number of reasons, to ensure, most of all, that there is alignment between what your overall vision is and what you want your financing incentive to be at.
Well, you might not know it, but Beth did not participate in that second project. She's carrying the weight for one of her colleagues, who Michael Baylett, who led that project. So thank you, Beth, for stepping in and presenting that. It was as if you were there, listening the whole time. So we're going to have a 15-minute break for lunch.